of Medicare Advantage, but also we hear you loud and clear that we also are aligned on the need to strengthen and improve the program, especially in some of the areas. And just in the short time that you've been, I feel like your time at CMS is already dog years as far as it's not even been a year. But also you've played such a role just in healthcare policy before coming in. But already just grateful for the work of your team and the partnering and just where we're mutually aligned. Again, I want to touch on some of the challenges that you've laid out and really getting your insight and some of the work that we know that we need to do together. You mentioned prior authorization. And as we're mutually committed with the agency on putting seniors first, but then focusing on what you shared about the need to address costs, but not lose quality, what do you see as the most critical when we look at prior authorization as being a really critical tool to address the needs of beneficiaries? What is the most important piece of prior authorization that we need to maintain? And then also, there's legislation that BMA has been supportive of, the Improving Seniors Timely Access to Care, that's e-prior authorization. And so if you can just speak to that aspect of prior auth.
The most important thing in prior auth to me is speed. So the prior auth would be part of that. It's infuriating to have the anxiety of an illness at the same time you're waiting for someone who's not really involved in your care directly to approve whether it's appropriate or not. And those are the frustrating cases we hear about, but they're also the ones that keep you up at night. And it's the worst thing possible to be waiting for a diagnosis for the doctor to call. But then if that's delayed weeks because of paperwork issues that we think are addressable, it's frustrating. I've spoken to members of the Medicare Advantage Consortium and insurance companies in general, and they share with me that almost half of doctors respond to prior auth requests with paper. And that signifies an additional problem, which is people don't trust each other. Right? Doctors have access to digital tools. At least 85% of clinicians have electronic medical record systems, so they should be able to respond pretty quickly. But that hasn't been built. Now, if it didn't exist anywhere in the world, I'd say, well, okay, well, that's the best we can do. But in reality, banking is a pretty good metaphor. Banking is built on a series of adjudicatable decisions that can be made instantaneously if the rules are written out clearly. So when I was doing my own research on prior authorization, I called around and I had my own personal experiences, but I'm a heart surgeon, so it's not, there wasn't that many prior auths. Most of the time it was clear that they needed the operation. So I called internists and especially general practitioners to hear how frustrating it was for them. And what they often shared was that in the prior auths that they were being asked for were very different between different insurance companies. And what you would do to quantitate that you were doing the right thing was also different. So for example, there are 15,000 procedures roughly that you could codify, and about 5,000 to 6,000 of them are the ones that get prior auth. But they're not prior auth by the same companies. So company A will have 3,000, company B will have also 3,000, but not the same 3,000. So as a clinician, as a provider, you don't quite know how you're being graded, and you don't even know what is the definition of a criteria that would allow knee replacement. So as an example, and this is something we're discussing within CMS as well, if we want to do prior auth for a knee replacement, you should say, okay, if it doesn't bend 90 degrees, you can replace it. Or 135, or 85, whatever the number is, pick a number. And then everyone knows that's the number. And then when I'm at my doctor's office and he's or she's trying to tell me what to do with my knee, we can quickly figure out my knee doesn't bend 90 degrees, or it does, and I'm in or out. Those kinds of decision trees have not been created. And I know they exist because hospital systems have done it. So then that brings me to the second big issue that we sort of wandered into, which is, do we need prior auth at all? So I think we do need it, but it's got to be done the right way. So that sort of begs the issue, well, do we do less procedures or less people? Less doctors and nurses are going to be filling it out. That's why experiences like I saw at Allegheny Highmark system in Western Pennsylvania is an interesting one. About 50% of their doctors, I am told, are given a gold card. So they don't have to do any prior authorization. Now, they are checked. And so the insurance company, I mark in Allegheny, will look to see, well, are you following best practices? And if you start to deviate, you come off the gold card program. Well, guess what? You don't want to make a mistake because you want to stay on the gold card program. That's really valuable. It's peace of mind, less effort, less staff, it's across the board. And the people who aren't on the gold card, they really want to get a gold card. So they're working overtime to make sure they're not having issues. And their businesses, as you know, being built around this. Kaiser, which doesn't do prior authorizations, they have other methods that I alluded to for doing quality control. They're opening, they have a side business now that's going, for example, in Pennsylvania, which is my home state, where they're actually offering advice and recommendations to build the guys and girls of the system up to be able to be at the same level with prior auth. These are clever ways of getting around a problem, which historically arose in ways that should not today be the standard of care. And that's one of the things I want to call, again, to the MA industry. We expect great things from the industry because there's so much talent in it. So when we start to see people coasting or not taking chances to improve the opportunity just based on technology that's available today, not pushing the industry to do more, it's a wasted opportunity. Again, it's like a great athlete that is playing okay, but not playing their best, doesn't seem that focused, and then all of a sudden people start finger pointing. And I do believe there's a lot more upside than downside, which is why I want folks doubling down on things they wanted to fix for a long time, but sort of fell to the back burner.
Thank you, and thank you for recognizing the need for prior auth, but obviously realizing that we need to improve on it. And also, just again, this is going to come up in some of the areas we're discussing, just again, in the short time you've been at the agency, already showing leadership in the work that you've done in addressing the prior auth and the volunteer effort with the industry, so thank you.
Thank you.
Another area that you just spoke to, and this is the benefit of having the administrator do a keynote before, I don't even sort of need these questions, I can just follow on what you just shared, is the challenges that we have, and there needs to be accountability. And in Medicare Advantage, we have sought to set a high bar when it comes to accountability and transparency, because that's necessary to maintain the stability of the program. We also need stronger accountability and payment accuracy and fee-for-service as well. And one more area where CMS, under your leadership, has already shown action is announcing the auditing every MA plan annually, and that's something that the Better Medicare Alliance has supported. And so when it comes to that, again, when we're talking about the focus of seniors, how do you see those audits building on the foundation of accountability?
Well, I think you want to trust and verify. If you didn't trust the system, you wouldn't be working with the system. But sometimes folks don't do their best, and you want to be there to catch that. And if you don't police the system, you send a message that bad apples might get away with stuff. And bad apples in general have lower cost of goods sold, right? Because they're not going to invest in quality. And in medical school, if someone cheats on a test, you throw them out of school. And when I was a medical student, I wondered, why are we so strict about that? I mean, I can understand penalizing someone, take a month off, get an F, whatever it's going to be, but why do you have zero tolerance and throw them out of school? It's because the best predictor of someone who's a serial malpractice physician is cheating in medical school. Because if you're going to cheat on a grade that would have just judged how much you've learned, are you going to cheat a patient? Are you going to cheat an insurance company? Are you going to cheat the government? Are you going to cheat people in your life that care for you? Yeah, most likely. And so I can't say it's universally true, but we can't take the chance. So by not checking, you allow things to happen that pervert the system. There's this great story in McCann, Texas, which was actually a nice New Yorker article on it years ago, but it opened my eyes to diversity in practice patterns. But it wasn't so much that McCann, Texas had the highest percentage revenue of Medicare payments for its citizens. It was that they had the worst results while paying the most money. So got everyone curious, what's going on in McCann, Texas? And it turned out that there was a traditional practice, a bunch of cardiologists doing healthcare the best they could. Not everyone's perfect, but they're all trying to do it the best they can. And an outside group came in. Actually, it was an individual who just wasn't very ethical. and started doing inappropriate procedures. Now, one of the best ways of getting good results is to do procedures on people who are healthy who don't need you. They tend to do really well, right? But they don't know that you cheated them a lot of times. So he was doing inappropriate angioplasties and cardiac catheterizations, and he did so well that he hired a partner. And then the two of them began doing the same practice pattern, again, inappropriate procedures, high revenue, low cost, and then they hired partners. And before long, they took over all the other cardiologists in McCann, Texas, all of them. So don't think of a bad apple as just an isolated incident. They're like piranhas. They will destroy the infrastructure. We're looking at this right now with examples of problems you guys have all faced, like skin substitutes. Skin substitutes were a $250 million business 5 years ago. It'll be over $13 billion this year. And it's very hard to justify that increased expense by outcomes, which really haven't been reported in ways that are at least discernible from the FDA's perspective as being a better quality experience. And we can't tell either. So we're starting to think, well, because if this had been policed earlier, could we have prevented this? And what are these guys going to do next? Because they're not going to go away. You know, they're hiring many, many new salespeople a week. So they're just going to shift to a different route. We've allowed bad players to come into a sector, and unless you drive them all out, they will just find other ways of eating at the fruit of the harvest. And we are going to do that in this administration. It's why I don't have much tolerance for this process. Again, the benefit of coming from the outside when you're in the private sector and knowing your entire career is not going to be serving as CMS administrator is I have a limited window of time to do the things I think are good for the country. I was sitting where you were last year this time. And so if you were here, what would you do now? Because you don't have the luxury of time to dilly-dally. What would you do now to make sure you cleaned up the neighborhood as best possible so you let high-quality folks practice as best they can with appropriate reimbursement and allow the system to flourish with people who are earnestly trying their best, not folks who are seeing it as an opportunity to take advantage of the system.
Thank you. A bit of a follow-up on staying on the theme of accountability and what you keep coming to with Trust in Medicare is we have lots of different best practices that we need to try to be looking at to improve the program, and one area is in home health assessments, which we'll be having a panel this afternoon with several of the allies. And one of the areas that we, again, have been talking with you and your team on is setting up some guardrails to try to make improvements there. Because we do, and we've already been hearing from seniors where they value the in-home health assessments because they feel it ultimately helps preventive care, and we do see health outcomes. But there still has to be some guardrails set up and accountability. And so as we're trying to retain stability in the program, what do you see about balancing the need for continued accountability while ensuring stability for beneficiaries in tools that ultimately are bringing in preventive health and using in-home health assessments as an example?
Mary Beth, I built my career around preventive health. I'm strongly supportive of home visits. What I'm not supportive of is coding problems that don't get treated or aren't a focus of treatment. And we jokingly say that we want to mediocritize coding. Like, I want coding to be a very mediocre talent set. You really shouldn't be dependent on coding. It shouldn't make that much of a difference to you. We know that coding generally predicts only about 15% of the variation in next year's severity, the reality of what happens to patients, their severity of their illnesses. So it's not that accurately helping us predict which diabetic is going to go into renal failure versus not. We have other tools that seem to be able to help us equally well. And I would make the argument, with the technology we have today, we should be able to gather all the information within the workflow that we need to adjudicate someone's severity of illness and appropriately compensate for them. And if we think that there's an additional benefit of coding, well, then you professionalize coding. You build systems that are designed to increase coding when it doesn't really translate to any changes in care. If I'm taking care of a patient and you have a 30% plaque in your carotid, that's very different from someone who needs limb salvage surgery. They both have atherosclerosis, but they have very different impacts on the healthcare system, and I should be graded very differently. So if I identify a problem that I don't treat, and I don't think warrants me getting involved in, should I get paid extra for it? That's it's not as easy a question to answer as you might think, but it, generally speaking, should be, I should get paid not equal if I have to treat it. And so I think that's part of the dance that's occurring here. I think with some of the at-home tools that are out there, both self-monitoring, but internet everywhere, so I get rapid responses. If I can track that someone is heading towards heart failure, and I should intervene in a timely fashion, that saves lives. The number one predictor of death at the heart failure admission is how long it takes to give them Lasix. Lasix is a diuretic, right? It's a pretty simple metric, but I can probably tell a day or two before you get admitted because you're putting weight on, of course, water weight, because you're going to heart failure because you had too many kielbasa's or something happened that went wrong. Then I could intervene and say, cut back on the salty food, increase your diuretic, come see us now. That's where I want to give advice to people, not just documenting the fact that you've got some esoteric problem that's common. And that's the other thing we're writing in the coding. We're asking you to code things where it's 99% true. Well, that doesn't help. It just costs you money. It's paperwork for us. We took 10 items off the list already. It's harder to add to take off, so our goal is to reduce the number of criteria that people can create it on, with the hope that, again, it won't matter that much anymore. Based on the things you do, we should pay you more for taking better care of someone who has more complicated problems. But I shouldn't rely on some third-party group to help figure that out for me.
Yes.
I mean, what I'm saying, I used to sit where you were sitting and hear people tell me this. So it's not like it's the first person. You guys probably going to say this 100 times today. You probably already said it a dozen times. But we have to act on these things, and it's remarkably challenging, which is why I'm blessed to have a great team. I joke with my team, who many of them came from the private sector, that my main goal in life, my main job right now, is to hire the smartest people I can find and make sure they don't kill each other. So if any of you are interested in helping, come on down. We can use more smart minds. But this is a generational opportunity to make some of the changes that are better for the industry. The other thing I find, Mary Beth, I don't know if you've noticed it, but when I say things that sound like they might be a bit harsher, folks who are industry leaders like it, because they're doing those things anyway. They just get dragged behind by folks who are getting away with not doing the job the best it can be done. And we tolerated for too long some of these players. And it's not even a player, it's not fair to say that. Within companies, there are these tug of wars. And we need to support the folks who are looking up. They see they have a vision for what their company, but also what MA can do. And each and every one of you have a possible role to help those people. Let them be heard more effectively, because those companies will do the right thing when those folks are heard better.
Well, appreciate you being able to see that we can do better. And again, just appreciate the outreach that's daily from you and your team as far as addressing those challenges. And again, when you opened this morning, you talked about the focus of beneficiaries. So here we are again on Open Enrollment Day. And you've talked about, and this is something we've been committed to, is what do we need to do to make that open enrollment process less complex? And so as seniors are making those choices, they feel that they have the support